This is my talk, Cesarean Scar Pregnancy, and I am referring to ectopic pregnancy or not. And I will also talk about intrauterine ectopic pregnancies. What is this lecture all about? My lecture deals with the everlasting academic and clinical debates about the nomenclature and classification of cesarean scar pregnancies as the first member of the placenta-accreta spectrum. To achieve this, first, I present the CSP in historical perspective. Second, I have to present the arguments and their sources in order to make sense and draw the necessary clinical conclusions to be able to apply them when encountering a patient with a pregnancy implanted in or on the site of her previous cesarean delivery scar or niche. So here is the short history of cesarean pregnancies. Lehmann in 1924 was the first to describe in German the Divertikelschwangerschaft or pregnancy in the diverticulum. A decade later, Capecci in Italian said placenta abbandonata in utero cesariato. In 1944, Schweitzer calls placenta increta destruens, in sectio cesarea abdominalis retrovesicalis. In 1947, Waltawski reports on uterine pregnancy in a cesarean section scar. And 1937, Irving and Herting, we all know, described the first cohort of placenta accreta. Rojas in 1946 said intramural pregnancy. Similarly, the term isthmic cervical and isthmic pregnancy was used. Over the years, only two terminologies survived, and they are cesarean scar pregnancy and cesarean scar ectopic pregnancy. The slowly changing terminology are a reflection of the gradual changes in the state-of-the-art OBGYN, also better understanding the pathophysiology of pregnancies in or near uterine scars. The older terms were progressively abandoned in favor of the use of modern descriptive and inclusive terms of cesarean scar pregnancy, and around 1990s, this term became established. In 2000, a landmark article by Vial said that, and they were the first to propose an original clinically based classification on the different phenotypes of pregnancy implantation at the cesarean scar. They say type 1, endogenous type, superficial implantation of the sac with progression into the uterine cavity, whereas in type 2, or exogenous type, with a deep implantation with progression outwards towards a rupture. The terminology describing CSP, the cesarean scar ectopic pregnancy, was introduced at the end of the 1990s, and I will talk about that separately. In 2002, Getzi said in the endogenous type of pregnancy can sometimes continue until a viable birth is possible, whereas in that exogenous type, the risk of life-threatening massive bleeding is high if a timely treatment is not undertaken. This was also supported and made public in a systematic review by Gonzalez and Tulandi. Here is the definition of cesarean scar pregnancy. As you all know, it's a potential man-made consequence of a previous cesarean delivery. Its rate parallels the rate of cesarean deliveries. The CSP implants on the scar or in the niche of a previous cesarean delivery, and before 7 to 8 weeks, the uterine cavity is empty. The location is the lower half of the uterus by the internal os under the bladder. It is not an ectopic pregnancy, and I will develop this idea of mine. Contrary to real ectopic, it can result in a live-born. Unrecognized or inadequately managed, this can lead to complications in all 3 trimesters of the pregnancy, and you can see there a rupture as well as placenta accreta spectrum. Here are some of the main classification of CSP in pictures. Lin 2018, Do in 2020, but no figures were available to me, and Ban, a very complicated one in 2023, and then finally Jordan's, that I will develop a little bit better right here. They define the first trimester CSP as three types in relation to the uterine cavity line and the serosal line. The type 1 in the gestation protrudes towards the uterine cavity. Type 2, the gestation sac is embedded in the myometrium, and the type 3, it's partially located outside the outer contour of the cervix of the uterus, and I will come back to this classification. Me and my group's involvement in the clinical entity started off with early articles in 2001 with defining the saline infusion that looked at the niche in the scar. That's the first article about the niche. 2012, 2 articles in the American Journal, a review, and then the diagnosis, treatment, and follow-up of scar pregnancies. Then we wrote that CSP is a precursor of PIS, and then that they share the same histology, both in 2014. Over time, these became the staples to prove the connection between CSP and PIS. Here is an article in 2017 from our group by Andrea Kalin Acton, and these are the prognostic signs based on the type of CSP, which is ultimately dependent on the residual myometrial thickness. There is a differential pregnancy outcome as a function of the residual myometrial thickness, and you'll see here the type 1 on the scar implantation with a 3 millimeter or more residual myometrium. This was associated with better outcomes, less frequent and less severe PIS, fewer hysterectomies, and fewer deliveries close to term. Type 2, in the niche implantation with 2 millimeters or less of residual myometrium, as you can see it here, that was associated with worse outcomes, more likely to result in severe PIS, leading to hysterectomy and preterm deliveries. The terminology describing CSP's Cesaría ectopic was introduced at the end of 1990s. After that, I disagreed and I submitted this article. Cesarean pregnancy is not an ectopic pregnancy. In all my writings, I said, never call it an ectopic pregnancy. Always call it simply cesarean scar pregnancy. My arguments were and are that CSP within the classic anatomic boundaries of the uterus, and true ectopics are not. Real ectopic pregnancies are extremely rarely result in a live offspring, and that always results in an article, and 50% of the CSP do result in a live offspring. And then the last one, treatments of true ectopics are not only less effective in CSP, but may require additional treatment and may have severe complications. And my arguments were, again, CSP is within the anatomic boundaries, ectopics not. And again, you see that basically these are my arguments that I hold even today. Now, I got clinically as well politically motivated rebuttals and counter arguments to my article almost at every single of my lectures. Here are the political consequences affecting the subject. The SMFM addressed a nomenclature issue regarding the terminology of CSPs. The SMFM decided to change the diagnosis of CSP to CSEP to help women to desire a termination. The old title was in the Consult Series 49, Scar Pregnancy, and I was part of the authorship. New title, Series 63 in the SMFM Consult Series, Ectopic Pregnancy. And my name is not there. I thought that this can be solved in a different way. Then Davor Jurkovic, my good friend from the UK, said it is an ectopic pregnancy, and he said a more ominous but presumably unintended consequence of my argument is the risk that in countries with a more restrictive approach to termination of pregnancy, including some states in the USA. Labeling scar pregnancy as a variant of normal could be used to limit women's choice regarding the management of these abnormal pregnancies. This would inevitably result in many women suffering severe, life-threatening complications, loss of fertility, which would be preventable by early intervention to treat the scar ectopic pregnancy. We replied, and I said it's a safety issue. We are aware of 2 maternal deaths in the US for which a radiologist's report gave a diagnosis of cesarean scar ectopic, which led to well-meaning, albeit ill-advised, clinician following a protocol of the American College of OBGYN using intramuscular methotrexate to treat a garden variety tubal ectopic pregnancy with, in this case, result in catastrophic results. Surely, the possibility that even one clinician may make such an error makes this more than simply a debate over semantics. In fact, this exchange has caused us to rethink a much larger issue. I said, why assign the word ectopic to anything other than tubal ectopic? Why a corneal pregnancy rather than corneal ectopic? Why a cervical pregnancy rather than a cervical ectopic? Why a cesarean scar ectopic rather than a CSP? Perhaps we should reconsider the entire issue of nomenclature. So I'm asking a question. What should we, the caretakers of women, do? Should we be consistent and practice according to the rules of clinical knowledge and call it a CSP is not an ELP, an ectopic pregnancy, and try to arrive to a consensus helping women to terminate CSPs? Or should we admit that there are contradicting views in the profession and that CSP is an ectopic pregnancy, give in, and thereby helping women? As far as I'm concerned, the case is closed. To help women, we, the caretakers, have to look the other way. The war for women's choice has to be fought in the political arena. And now here is the latest, hot off the press article about redefining ectopic pregnancy, and called the Diagnosis and Management of Extrauterine and Uterine Ectopic Pregnancy, new term, by the group of Davor Jurkovic. And they have a graphical abstract, which I will come back to, and they say in recent years there has been a rapid rise in the prevalence of ectopic pregnancies, and that there are located outside the uterine cavity but within the confines of the uterus, the largest burden of which is from cesarean scar ectopic pregnancy. This has promoted new terminology and classification of ectopic pregnancies, to raising awareness and minimizing the risk of misdiagnosis. Uterine ectopic pregnancies are very difficult to diagnose and manage, and they are also associated with increased maternal morbidity, mortality, and adverse reproductive outcomes. Another challenge, which is peculiar to uterine ectopic pregnancies, is their potential to progress to reach fetal viability, albeit with high risk of extreme prematurity. This requires women and clinicians to make difficult decisions about whether these pregnancies should be terminated to protect maternal health, despite some possibility of good fetal outcome. And here is the graphical abstract. I'm only looked, when I read it, to the lower part of it, referring to cesarean scar pregnancy. And I'm detailing here the section uterine pregnancy. So there are extrauterine and uterine pregnancies. The extraectopic pregnancies can be tubal, in the interstitial parts of the tube, ovarian and abdominal. The uterine develops in the confines of the uterine vesicle peritoneum. That's what their point is. My point is the endometrium, not the visceral peritoneum. And therefore, I hold my own view of whether it's an ectopic or not. And here they include cesarean scar, cervical and intramural pregnancies. They may also develop within uterine anomalies. So it is complete versus partial uterine pregnancy. A further important to my view overclassification that relates to whether all or part of the pregnancy breaches the anatomical boundaries. For example, where a uterine pregnancy has no visible connection to the uterine cavity, it's called complete. And here is the picture on the right side, you see it. But pregnancies that are part within and part outside the cavity should be, by their nomenclature, be partial. And you see it right here on the very right side. And then there is intramural pregnancy. This is caused by the breach or abnormalities of the endometrial myometrial junction, which is often iatrogenic. They may result of myomectomy, classical cesarean section, or perforation or myometrial trauma. Intramural pregnancies have also been found within adenomyosis. The authors create an exception. They say important pregnancies may be in close proximity to a cesarean scar, but not meeting the diagnosis of CSP. And here is the picture. They say if low posterior implanted pregnancies do not breach the endometrial myometrial junction, they do not constitute cesarean scar ectopic pregnancy. And here are the pictures and my ovals depicting them. However, times change, and we change with them. Tempora mutandur, nos et mutamur in illis. It's a Latin proverb. And because of this, our group wrote article Cesarean Scar Pregnancy Spectrum, a proposed standardization, classification, and terminology for the reporting of pregnancy developing the uterine cesarean scar. So here are the reasons writing it. There is academic and clinical debate, as I showed you over in the first couple of slides, of cesarean scar pregnancies with the relevant social aspects and management. We offer in this article a solution to the controversy about the cesarean scar pregnancy and cesarean scar ectopic pregnancy. They exhibit a spectrum of different pathophysiology and different outcomes. After creation of the placenta accreta spectrum, we suggest unifying the terminology of the scar pregnancies. And here is the old one, type 1 and type 2, with the cartoon and two pictures, one on the scar, one in the niche. We know all of this. Now, we created an all-encompassing term, cesarean scar pregnancy spectrum, including the different presentation, critical severities, and complications. We categorized the CSP as on the scar pregnancy, or CSP, and cesarean ectopic pregnancy as EP, distinguishing their clinical presentation and risk stratification. It can make reporting to permit shared decision-making for expectant management of OCSP, better information to patients with CSEP of the potential risks, and selecting management of the CSEP according to its place on the spectrum of the scar pregnancies, as well as the gestational age. And here are the definitions. You see it on the left side on the scar, empty uterine cavity, and the endocervical canal, placenta gestational touching hysterotomy scar with or without placenta previa, and the overlying residual myometrial thickness at least 3 or more millimeters, and the ectopic pregnancy, similarly, empty uterine cavity and empty canal, but the placenta and gestational scar is embedded in the niche of the hysterotomy scar. It can be without or with placenta previa, and the residual myometrial thickness is less than 3 millimeters. And here are the pictures that we attached to the article. On the upper part, the cartoon, and the line that I consider the important one in the cavity and one in the surface of the uterus, in the anterior surface, and the pictures. I cannot emphasize enough to use the proper technique to measure the RMT between the bladder wall and the gestational sac, and you can see that right here in this enlarged pictures that has the cervix, the internal and the external os, and the gestational sac. the bladder and the measurement of the RMT that should be done very precisely. Now I have two tables, and they will be included in the syllabus that you can obtain, and you can study it. But even in this one, I say the clinical comparison of on the scar and the scar ectopic pregnancy in terms of implantation side, residual myometrial thickness, anatomic integrity, direction of growth, ultrasound features, natural history, risk of rupture, progression to PAS, surgical complexity, clinical prognosis, and supporting evidence. And I look at the on the scar and the ectopic scar pregnancy. And here is a second table that shows the clinical outcome by the proposed type of cesarean scar pregnancy spectrum. And on the left side, you see the on the scar, which has two kinds, lower uterine segment and upper uterine segment, and the scar ectopic with the outcome and the estimated risk. Here are two pictures, and this was one that ended without hysterectomy. And the decisive issue was the residual myometrial thickness that's more than 40 millimeters. Here is another one that ended with a hysterectomy, albeit with minimal blood loss. But even in this one, the decisive issue was the RMT was less than 4 millimeters. In summary, I slightly adapt and concur with the logical arguments about scar pregnancies. I placed CSP in the historical perspective to see how nomenclature changes. I try to reveal the origin of the term ectopic and my efforts to dissuade its use. There are too many classification systems. None were clinically validated, and they are too complicated to use. In my view, and is supported by data, there is in fact only two types of CSPs based on the RMT. Type 1 on the scar, OCSP, with a considerable more than 3-4 millimeters with better outcome, and type 2 in the niche, or CSEP, with a thin, less than 3 millimeter, with high risk for guarded outcome. I suggest not to use the Jordan's intermediate type. It places you and the patient on the fence with a difficult counseling regarding management. Thank you very much for your attention, and I hope that I made some sense and you will follow some of my suggestions.